Okay, Chapter 8. So as we've already discussed, we have several things that actually occur. We have the computer that actually processes attenuation data. And as we know, attenuation data is the amount of absorption or the scatter of radiation. So after the computer processes this, it generates something like this, which is a numerical CT image. However, this would be very uh, unorganized and very indeterminate, because how can you take these numbers and really define what you're looking at? You can assume that because we have this string of numbers right here, that we're going through something very dense, probably some type of bone, but how can you tell what type of bone? If I asked you what type of bone this would be, you would have no idea. So in order to do this, the computer uses these numbers to formulate a gray scale image. We use plus 1000 for bone, negative 1000 for air, and somewhere around 0 for water. So this brings us to a grayscale image. This grayscale image is then manipulated into something like this, which corresponds to the CT image. And so the finished product is something that is very useful and we actually have to have, but there are several steps to get there. So image post-processing. Image post-processing has become an integral part of the operation of the computed tomography scanner, the purpose of which is to allow the observer to manipulate or change the image quality characteristics such as brightness and contrast to enhance diagnostic interpretation of images. Things can include both 2D and 3D reconstructions. So basically, the whole thing about image post-processing is manipulation. It's about how to get better diagnostic quality or better images than what you previously had. This is accomplished through the use of sagittal, coronal, and axial scans in the 2D plane. These normally fall under the banner of MPRs or multiplanar reconstructions. Then we get into 3D, where we have volume, VIP, and MIP. So the definition of image post-processing is the use of various techniques, such as processing software or algorithms, that help to modify the reconstructed images displayed for viewing and interpretation by an observer. So you definitely want to know this definition. And we see that there are several advantages. Number one is the changes in the image helps to display certain structures better, so it increases visualization. However, one very important point to note about these post-processing operations is that they do not produce more information content. So you definitely want to put a star beside this. It only amplifies the data that is already there. You can't add more data in than what you already have. You have to acquire the images, and they have to be of a certain quality, or else all of your other images will be of low quality as well. So as a result, the information content in the processed image is always less than or equal to that in the original image. And what we mean less than, you can remove certain things, like if you're wanting to isolate certain bones, you can remove other bones to help visualize this area. So the image quality or the information content would be less than what you originally started with, but you can't add more to it. For example, if you clip something, just a routine example, if the patient is moving their head and you're not able to control it, and in the middle of your scan, the patient tilts their head down, and so where the scan should have stopped, and it does, you actually clip the vertex of the skull. and you have to rescan or scan this image, that would, if you initially just completed the scan there and not added images to acquire this portion of the skull, then you could not somehow find this portion of the skull without scanning it, because the information content would stop where you stop scanning. So this is accomplished using two techniques, which fall into two categories: linear or non-linear. Linear refers to image smoothing and enhancement, whereas non-linear refers to grayscale manipulation. So basically, what linear means is that you are kind of utilizing different filters to smooth out the image and enhance the image, whereas grayscale manipulation will fall under window and leveling. One such common algorithm of interest used in CT routinely by technologists and radiologists alike is gray level mapping. It's commonly referred to as contrast enhancement, contrast stretching, histogram modification, histogram stretching, and or windowing. Typically we'll hear it referred to as windowing more often than anything else. And this would fall under the non-linear portion. So what is windowing? As we saw before, CT images begin as a numerical image, which has to be changed from that numerical image into a grayscale image. This is when the image becomes diagnostic in quality. Without this, the image would not be diagnostic. You couldn't tell any pathology by numbers. The numerical image consists of a range of CT numbers. We see that lower numbers, such as -1000, are considered to be black, and numbers such as +1000 are considered to be white. And the reason for this is bone is white, air is black. And so -1000 refers to a lack of density, whereas +1000 refers to increased density. Windowing refers to a method by which the CT image grayscale can be manipulated with the CT numbers of the image. And so basically what you're doing is you're raising or lowering CT numbers. This allows structures such as bone, soft tissue, even the lungs to be visualized to a greater extent. The picture, contrast, and brightness are easily changed with two control mechanisms such as window width and window level. Here we see an example of changing the windowing of an image. Here we have a typical abdomen window. As you can see, the contrast enhancement of the liver is quite easily distinguished. A liver is normal density, a slightly higher density than we have the muscle here. We see the heart having a little bit of contrast in the right ventricle, spleen coming in, aorta has contrast in it, and we see the ribs. And so this is your typical abdominal window and leveling. However, if we were to modify that so that we can better visualize some structures, we see that this is almost a bone window here. Notice that the contrast and the liver have each been kind of toned down, and now they have a gray appearance. And you have a cyst here, and the bones don't necessarily stand out as white. So we would say that this would have low contrast, simply because there are multiple shades of gray in this and fewer whites. This, on the other hand, notice how white the contrast portions of the skin are. The kidney is glowing white, whereas the cyst has a totally different color. Notice how the liver almost looks like it has hemochromatosis, which is excess iron deposition inside of it, and the spleen looks like it has excess density as well. So this would be more along the lines of high contrast. You have whites, and then you have black, and then few gray. Low contrast, on the other hand, has higher ranges of gray, whereas very few shades of white and black. And our first image would be normal contrast. So hopefully you can see the difference in each of these images. So that brings us to window width and window level. Window width is the range of the CT numbers in the image, and it determines the maximum number of shades of gray that can be displayed on the CT monitor. Window level is the center or midpoint range of the CT numbers. We see that when window width and window levels are changed, the image contrast and brightness can be optimized to suit the viewing needs of the observer. So a large window width means that there is a long grayscale. And what we mean by long grayscale is a large block of CT numbers that correspond to some value of gray. So there's going to be a lot of numbers that apply to gray. There's going to be several different shades. A large transition between the whitest white and blackest black. So you might have white and black, and because this is going to be low contrast, you're going to have many different shades of gray lying in between. If this were a short window width, you would have white and black. You might only have a few shades in between. A narrow window width equals a short grayscale, which we have here. You have white to black being very short in terms of transition, and there's fewer in between numbers, so fewer numbers that correspond to gray. So manipulating window width and window level, it's important to note that CT numbers vary among different scanners. The range for some CT scanners varies from -1000 to +3095 or 3095 Hounsfield units, so that gives you a total of 4095 CT numbers. For other scanners, it may be -2048 to +6143. It gives you a total of 8191 CT numbers, or 8191 CT numbers. So a lot of numbers in between. So we're not going to get caught up in what the scanners say or how many numbers the scanners have, because that's going to be specific to each manufacturer. And so we really can't designate or determine this. What we can determine is the tissue grayscale is stretched out with white at one end, black at the other end, and shades of gray in between. So that's going to be the commonality between each different scanner's type of scale. The grayscale then changes as the window width is expanded or narrowed. So once again, if you have a short window width, it means that you have fewer shades of gray. And if you have a long window width, then that means that you have more shades of gray corresponding to this. So wide windows are usually 400 to 2000 Hounsfield units. So it has this amount in between the area. And it should be used to encompass tissues of greatly differing attenuation within the image, such as fat, fluid, muscle, lung, and bone. So a wide window will help display all of these. Narrow windows, on the other hand, are between 5 and 350 Hounsfield units, meaning that there's a very narrow shade or a very narrow window. And it should be used to display soft tissues within structures that contain different tissues of similar densities. And this goes for the brain and the liver. So basically what you need to know is what you would use a wide window and a narrow window for, what type of scan. And if you'll notice, this wide window is going to be typically used for abdomen and pelvis. In general, the viewer can alter the contrast of the CT image by changing the window width. So instantly you can change the window width. When the window width is large, such as a wide window width, 3 different structures, such as the lungs, liver, and pelvis, have the same gray tone. On the other hand, with a narrow window width, there is a very sharp contrast to the point where the lungs appear black, bone appears white, and the liver is shown as gray tones. Image contrast is optimized with the use of a medium window width. And so let's go back to this. 350 to 400 would be a medium window width, and that's where we typically will see an abdomen pelvis. The following conclusions may be drawn about the effect of window width on image contrast. As the window width increases, contrast decreases. And this is because we have more gray. As the window width decreases, the contrast becomes greater. The image appears totally black and white with a window width of 95. And so a window width of 95 will give you black, the blackest blacks, and the widest whites, and nothing in between. Contrast is optimized with a medium window width setting and is probably best depending on the observer's subjective impression when the image is recorded with a window width of 499 for the optimization of certain abdominal structures. So as we saw before, around 350 to even 500 will be an appropriate level for imaging the abdominal structures. But notice that this is usually dependent on the observer's subjective impression. So not everyone is going to look at the image and say that this is correct or the most correct way. Usually it depends on how you've been trained and what kind of suits your palate. Some physicians and some techs like to look at structures darker, and some like to look at them lighter. And so it's all becomes subjective because we do have this range in this freedom of being able to adjust things as we see fit. So the effect of window level on image brightness. Once again, remember that window width, contrast. Window level, that's your brightness control. Okay, so as the window level moves toward the higher CT numbers, generally white, more CT numbers with lower values, generally black, are displayed. So if we have a scale, and this is white and black, and the window level is supposed to be the center point, and if you move it more towards the white, this means that there's going to be more area underneath, which is going to correspond to black. As the window level moves toward the lower CT numbers, more CT numbers with higher values are displayed, and the image looks white. So if you move it towards the white or the higher density, then you're going to have a blacker image. If you move it towards the black portion, you're going to have a whiter image. Here we have an example of narrow and wide windows, and also the effect of window leveling on brightness. As we can see, image A is very bright. It's got a lot of pretty much white tones showed, and the reason we can say that is because we can see the internal structures of the lungs very well, and also we would assume that this is a very narrow window because we see whites and we see blacks, but we don't see a lot of gray, very few in between. Image B, on the other hand, as we can see, we have the right pulmonary artery as well as the pulmonary trunk. We have descending aorta, superior vena cava, descending aorta. We have the corona with the left and right mainstem bronchi. However, we can really see the vascular structures very well, and we can even see some of the soft tissue structures such as fat. We can see muscles here in the axillary region. We can even see the sternum and the ribs. However, we can't see the internal structures of the lungs, and so this would be assumed to be a medium width, and notice this will be a fairly middle window level, so you're getting equal amounts of white and black. Here's another example. Notice how gray image A is in comparison to image B. Gray to the extent that you can really visualize the spine and you can see the ribs very well, but in terms of the contrast enhancement in the liver, you can see these tiny dots but not very well. You can see some of the bowel enhancement, but that's pretty much it. You get no definition on the right side. You can see the kidneys, and you can see that they have contrast, but notice how gray it is. So this would be a very, very wide window width because you have multiple shades of gray, whereas B would be a normal or medium window width because we can see the liver being gray with points throughout. We can see the structure of the aorta. We can see the kidneys highlighted. We can see the fecal material inside the bowel, as well as the bowel contrast. And we can even see the muscles in the back. And we do see visualization of the ribs as well. Maybe not to the same degree that we do with the bone windows. So, as you can see, this would be a normal to medium window width. And so I don't expect you to know what these numbers are for these window widths because each manufacturer is going to be very different. The important thing is to know that each will demonstrate parts of the anatomy better than the others. Whereas we see the normal window width will demonstrate the vascular structures as well as the bowel and the liver and even the renal system and the muscles. We see that in terms of bone, wide window width is definitely easier to look at the bone. But once again, this is all subjective. Some people don't like looking at a wide window width. This image once again illustrates the effects of window width. As we can see in the lower right hand portion on each of the images, we have the window width. So image A is going to be 603, image B is going to be 499, C is going to be 249, and D is going to be 95. So remember what we said about 95, where you're going to have white and black, and there's going to be really no gray in between. And 603 is going to represent a very wide window width. And so, as we can see, there's tons of gray, only black in a portion of the stomach, but everything else is kind of grayed out. If you ask me, there's not a much or a huge difference between image A and image B because we still do have a lot of gray. And honestly, for me, the book says that 499 is the most applicable thing to visualize abdominal structures, but I kind of favor that you need around the area of 350 to 450, being that you represent less gray, and so it would make the vascular structures kind of stand out a little more. However, if we go too far, we get tons of whiteness, and so we can see that we lose some of the definition here on the border of the liver. We'll see some of the vascular structures, but we don't see all. We can see differentiation of the air in the stomach, and we do see that we have a visualization of the vascular structures of the aorta. However, we do kind of lose some of the definition simply because of it being blatantly white. And continuing on this trend, we see image D, where we totally lose any of the vascular structures because it all looks like one big white mess, and we can't really see anything. So out of all of these, the image with the most diagnostic use would be image B, simply because you can see all of the structures that you would need to. Image A, everything is grayed out. Image D is too far to the opposite of image A, and image B is just about right. So this kind of demonstrates where you would want to see things, or how you can best visualize them. As we see, the lungs tend to gravitate towards lower CT numbers, liver is in the middle, and the pelvis is usually higher CT numbers. So lung is going to look black, liver is going to look gray, and the pelvis is going to look white. So a narrow window width will equal sharp contrast, and so you only have about one shade of gray for the liver, and one shade for the lung. If you go to a medium width, you're going to have everything becoming gray, the lungs becoming gray, pelvis even becoming gray, and then white. If you have a wide window width, everything is going to become gray to a various shade, and so you're going to lose a lot of definition. This is why medium width indicates the optimal contrast, because it allows visualization of pretty much all of the structures that you'd be looking for. So that brings us to two-dimensional image processing and multiplanar reconstruction. Multiplanar reconstruction or multiplanar reformation, such as MPR, sometimes referred to as the image reformatting or image reformation, not to be confused with image reconstruction, is a computer program that can create coronal, sagittal, and paraxial images from a stack of contiguous transverse axial scans. The sagittal image is a plane that divides the body into left and right segments. The coronal is a plane that divides the body into front and back segments, and the paraxial image defines a plane that cuts through the coronal and sagittal planes in the longitudinal direction of an anatomical region. We also have the ability to utilize irregular, oblique, and other views. The regular view, such as linear or curved, can be reconstructed from a stack of contiguous transverse images. The oblique view can be reconstructed with at least 3 arbitrarily defined points in different transverse images. In reformatting, the computer program uses any set of points to build an image of the selected plane. So here we see all of the planes kind of demonstrated. We have the scanogram, the image is acquired, and then we can do coronal. As you can see, we have the mastoid air cells here, spine, and we're looking into the brain, and we're scanning with this being front and this being posterior. We're scanning this way. We also have paraxial, and as you can see, it's kind of an oblique plane, something like this. And the sagittal is a plane that divides left and right. And as you can see, we have the oral pharynx here, we have the brain stem, we have cerebellum here, or cerebellum here, and that's pretty much all of the planes that we can. However, there's other things that we can do that this image really doesn't visualize. So the major advantages of reformatting include the following. To enable the visualization of specific structures such as the optic nerves and lesions in relation to surrounding structures. So it allows better visualization. Number 2, to determine the true extent of lesions or fractures and to help localize lesions and interarticular bone fragments or foreign bodies. So you can kind of determine how large lesions are, or how fractures have kind of went through the bone, how everything needs to be pieced back together. So it greatly helps and benefits people who are going to have to be undergoing surgery, or if you have foreign bodies located in an area of the body, it allows you to see where they are and how deep they are in relation to specific anatomical structures. So it gives many physicians an excellent kind of bouncing point so that they can see what they're going into. However, one major disadvantage of MPR relates to the image quality. Image detail is not as good as that obtained in the transaxial images. Image quality depends on the quality of the axial images. It's important that the patient does not move or breathe during the scanning procedure. Any movement will disrupt this. I'm sure if you have experienced this on CT, you won't forget it, where the patient has, you've been doing maybe an abdomen and pelvis, and the machine instructs the patient to take in a big deep breath and hold it, and the patient maybe halfway through the scan breathes. And so initially you don't know whether this motion has created tons of artifacts or not. However, after looking at the thins and trying to reformat images, you'll probably notice that there's a significant amount of motion, and where the patient has let their breath out and breathed in, it's created kind of a blurring stair-step pattern to where you're seeing anatomy come in and go out, and you're seeing it come in again. And so if the patient moves, breathes, things like this, it can greatly affect our ability to utilize images such as sagittal and coronal. Also, plane thickness affects the image detail. Thick planes result in blurring and loss of structural detail. I always think back to we had just begun utilizing helical scans for brains. Up until then, it had been strictly for trauma situations because we typically utilized just straight axial scans, utilizing stop and go technique. And I had a patient one night that it was ordered CT head, and the ER physician didn't say they wanted any specific reconstructions, anything. And so I scanned the patient, and we were still using at this time stop and go technique. And what we talk about in terms of stop and go technique is you scan one image, the patient table then moves, you scan another image, patient table moves, scan another image. And so it would take you probably a minute to minute and a half to acquire a brain scan. However, the patient really wasn't complaining of any structural pain such as a bony abnormality or any history of trauma. So I scanned the patient. Probably in an hour, the ER physician says, I would like some of those 3D reconstructions for this patient. And so I told the ER physician that there is really no way that I can do that because I scanned in a thicker plane because that was our protocol at the time, and there would be no way to actually get good looking NPRs. However, the issue was important enough that the physician recommended that the patient have these images, and so I told the physician that I would have to rescan the patient again just to acquire images that are contiguous so that I can do these images. However, the physician felt that it would be worthwhile for the patient to undergo, and so I had to scan the patient again. But what we looked at was the slice thicknesses were so large that the patient on the skull had an appearance like this, a stair-step pattern, instead of a normal smooth texture. And this is because there's a lack of information in between these areas, and so the scanner is trying to build the scan and stack them on top of each other, but there's not enough information to do so. So it's very important to remember that thick planes can sometimes be your enemy when it comes to reconstruction. So, three-dimensional images. 3D imaging in CT belongs to a class of digital image processing referred to as image synthesis, which creates images from other images or non-image data. It's used when a desired image is either physically impossible or impractical to acquire, or simply does not exist in the physical form at all. 3D imaging, we all know, is gaining widespread attention in radiology because it's opening up so many different venues. We're seeing this with virtual endoscopy. We're seeing all of this fly-through modes being utilized for even things such as tracheal lesions, to go through blood vessels. All of this is very useful and it's rendered simply because of 3D reconstruction. Already 3D imaging is used in CT MR imaging and other imaging modalities with the goal of providing both qualitative and quantitative information from images to facilitate and enhance diagnosis. So the real reason that we do all this is to just simply enhance diagnosis, to give the patient the best quality of care and the greatest quality of examination that we can. So the general framework of 3D imaging includes 4 major steps: data acquisition, creation of a 3D space, processing for 3D imaging, and then 3D image display. So we have visualization tools. Visualization tools such as windowing are computer programs that provide the observer or diagnostician with additional information to facilitate diagnosis. Visualization tools include a range from basic to advanced things. Basic tools are computer programs integrated into the CT system with the following capabilities: multiple imaging and multiple windows, image magnification, evaluation of geometric characteristics such as distances and angles, superimposition of coordinates on the image to provide a reference for biopsies, and highlighting in which the pixels in certain regions of the image can be made to appear brighter. Number 6, CT histogram, which is a plot of the pixel values as a function of the frequency in which each value occurs. This can be done for the entire image or a portion of the image as defined by the region of interest. ROI, or region of interest statistics, which allow for statistical calculations such as the mean and standard deviation within the ROI. ROI transfer, whereby the ROI can be transferred from slice to slice. Split imaging, in which an image can be split into 2 detailed thin slices, and fused imaging, in which 2 contiguous thin slices can be fused into a single thick slice. Optional software packages are also available for dental CT applications, dynamic CT networking, workstations, and 3D imaging. Sometimes vital information such as ROIs and measure certain things. Split imaging is something that we all probably have done, or maybe not split imaging, but fuse imaging. Something that we definitely have all done, where we take thinner slices and make thicker slices out of those. Is one of the many things that occurs in the reformation process. Advanced tools, on the other hand, require powerful computer workstations with advanced image processing capabilities and increased memory to handle the vast amount of data used in various visualization techniques. 3D visualization tools allow for the user to render various 3D images from the axial data set. 3D rendering falls into 3 categories: SSD, which is surface rendering, VR and MIP, and MINIP. Computer tomography angiography is a relatively new technique based on volume scanning principles. CTA is an application of 3D imaging and is becoming more popular in the examination of the circulatory system. And examples of CTA visualization tools include the 4-dimensional or 4D angio, vessel tracking, skull removal, and multiple target volumes. In 4D angio, the 4th dimension is opacity instead of time. Changes in the opacity values of various tissues enables the observer to simultaneously visualize bone, soft tissues, and vascular structures. Therefore, both foreground and background structures are visible. Preferred over conventional MIP techniques for the visualization of aortic aneurysms, renal arteries, stents, and carotid bifurcations. The vessel tracking tool allows the user to produce a set of NPR images or batches, including curved NPR images. For the entire vessel, the skull removal tool facilitates the subtraction of bone of the skull from the CTA image and allows the observer to visualize very detailed images of the vessel and soft tissues. Cine visualization tools allow the user to view a large set of images very quickly. As the name implies, cine means movie, and that's what this kind of allows you to do, is visualize all of these images very rapidly. Advanced quantitative measurement tools facilitate measurements such as distances, angles, areas, means, standard deviation, minimum and maximum voxel values, density value, and Hounsfield units, density histogram for particular ROI, and volume of 3D objects. Image fusion tools allow the user to combine images from a wide variety of imaging modalities such as CT, MR, positron emission tomography, or PET and single photon emission computer tomography to facilitate diagnosis of tumor localization and quantification, surgical planning, and oncology planning. So what we're striving to do now is integrate everything together to where we can visualize or utilize different scans and go through the same area at the same time so that we can see what it looks like and how it can be better visualized through all modalities. Virtual reality visualization tools include Voyager and 3D Navigator. These tools create 3D and 4D images of tubular structures such as the colon and bronchi and allow the user to fly through the images of hollow organs in a technique referred to as CT virtual, which is gaining widespread attention in radiological imaging. We see this many times where we're using virtual endoscopy and things of that nature so that we can use less intrusive methods and still aid in a very definite diagnosis. However, the one thing that kind of keeps CT virtual endoscopy back for the moment is the fact that you can't take biopsies. While you can visualize certain structures, it does little to alleviate the fact that if you see something significant, you will have to take a biopsy of it. So the patient will have to undergo patient will have to undergo a colostomy. The patient will have to undergo a procedure regardless anyway. Chapter 9. So, in general, the image quality of a computed tomography scanner can be described by several key performance parameters, such as high contrast, spatial resolution, low contrast resolution, temporal resolution, CT number, uniformity, and accuracy, noise, and artifacts. So we see that the images are defined by how good the scanner can actually acquire them. These parameters are influenced not only by the CT system and its performance, but also by the operator's selection of protocols such as the X-ray tube voltage in kilovolts tube current in milliamperes, slice thickness, helical pitch, reconstruction parameters, and scan speed. Everything can affect how the scan actually is performed and ultimately what kind of images are actually acquired. We know that trade-offs have to be made between image quality, dose to the patient, system limitations, patient conditions, and clinical indications. So we know there is never going to be a perfect ideal situation, especially when you're working in a hospital setting versus an imaging center. While an imaging center typically has more along the lines of walking and talking patients, hospitals, if you're doing throughput from the ER, typically may not have an ideal patient. And so you have to come up with compromises, what can be traded off so that you can actually acquire the scan and get as great of images as you can, but do it in a timely fashion. So that's something that has to always be in the back of your mind. So if we first begin by looking at what high contrast spatial resolution is, we see that it describes the scanner's ability to resolve closely placed objects that are significantly different from their background. Historically, spatial resolution was defined and measured predominantly within the scanning plane. However, with the popularity of multi-slice volumetric helical CT, the cross-plane resolution becomes just as important. So basically what high contrast spatial resolution is how can you detect several objects that are vastly different from their surroundings. So if we'll notice, this bullet point is much different than this area, and so how can you visualize the two? The in-plane spatial resolution is specified in terms of line pairs per centimeter or line pairs per millimeter. A line pair is a pair of equal-sized black and white bars. And we're not going to worry so much about the definition of it, but we're going to worry about, moreover, the effect of resolution. We see that many factors affect the in-plane spatial resolution, such as X-ray focal spot size and shape, detector cell size, scanner geometry, and sampling frequency. All of these things are largely determined by CT manufacturers, and we have very limited control of those, such as the detector cell size, which we can kind of determine by slice thickness, and sometimes the X-ray focal spot size. But other than that, we have very little control. Most scanners have more than one X-ray focal spot to account for an increased tube loading. Just as your X-ray, typical X-ray conventional tube has more than one focal spot, we see that CT is much the same. By properly selecting the X-ray tube current, an operator has the option to use either the small focal spot, which is a lower tube current, high spatial resolution, or the large focal spot, which is higher tube current but lower spatial resolution. So basically, how well are you going to be able to distinguish small things that have great density differences? The small focal spot is going to be able to do it very well, but the large focal spot is not going to be able to do it very well. But the trade-off is you can utilize a higher tube current and you can penetrate larger patients or more dense areas with the large focal spot. We also find that the in-plane resolution is also strongly influenced by the reconstruction algorithm, such as convolution and back projection. As we've already seen, if the projection profiles don't have convolution or filtering, blurring results. And so to sharpen the image, the convolution process or a filter is applied to modify the frequency contents of the projection before back projection actually occurs. We saw this as the elimination of the star pattern. In general, these algorithms are applied to emphasize soft tissue and bone. The former is applied to the midbrain, pancreas, adrenal, and or any soft tissue region, and the latter is applied to bony structures such as the inner ear and the extremities, as well as the spine. It's also worth pointing out that increased noise often accompanies spatial resolution improvement. So basically, you're going to have increased noise, or you're going to have loss of detail even though you're attempting to increase the spatial resolution. Another parameter that affects the spatial resolution is the reconstruction field of view. So here we can see the difference in image A and image B. So we would say that this has very low spatial resolution, where image B has very high spatial resolution. The reason we can say that is because the brain has a certain density to it, and we can visualize the bony anatomy as well. Here we have air in the sinuses, as well as we have some mucosal thickening, very important in this area. Here in image A, we cannot visualize very much of anything. We can see a little bit of the sinuses, but that's pretty much it. So image B would have excellent spatial resolution, where image A would not have any. Spatial resolution becomes very, very important when we're looking into the lungs. Image A and image B kind of demonstrate this very well. We have image A, which has somewhat okay spatial resolution, but nothing like image B. Notice how image B has the ability to distinguish these very tiny points of the inner workings of the lung, whereas image A really doesn't. Also notice the haziness and blurriness that is accompanied here versus what we have on image B. So image B would have very high spatial resolution as well. So that brings us to cross-plane spatial resolution. The introduction of helical, spiral, and multi-slice or volumetric CT has fundamentally changed the way many radiologists view CT images. Technologists have enabled radiologists to view images in 3 dimensions by using multiplanar reformation, maximum intensity projection, or volume rendering. It's difficult to tell from the image alone whether the data was acquired slice by slice or directly in the coronal plane. So we've gotten so good at demonstrating images that sometimes it becomes very difficult to discern whether the patient was actually scanned in the coronal plane or we just reconstructed it. The spatial resolution of the state-of-the-art scanner is nearly isotropic, meaning that for every plane it's virtually the same without any decrease in resolution. Improved cross-plane spatial resolution also reduces artifacts caused by partial volume averaging. Thin slice imaging of the lung is currently the most accurate non-invasive tool for evaluation of lung structure. And so that's something to keep in mind and put a star by, that this has become so accurate that it's pretty much a standard now for evaluating lungs. Here we can see a patient who has a scan, and scan A is one type of resolution, scan B is another. As we can see by the caption here, this is a high resolution scan, and I'm sure as we can guess, image B is the high resolution scan. Notice how we lose all kinds of detail in these areas in which I'm circling. And notice how on image B we have clear definition of all of this disease in the lung. We do have excellent abilities to visualize all of these small internal structures, and it can be pretty much defined that this is a very high resolution scan. So low contrast resolution. One of the key advantages of CT over conventional radiography is the ability to observe low contrast objects whose density is slightly different from the background. So, as we all know, it's very difficult in conventional radiography to distinguish certain things. Many times, the bowel is really hard to distinguish if you're doing just a KUB. You can't really pick out specific parts of the bowel. And this is because conventional radiography doesn't have as high of a sensitivity as computer tomography. And that's what we're talking about, is basically the sensitivity of the system. And that's the ability to observe the low contrast objects. CT can image tissues that vary only slightly in density and anatomic numbers. So in comparison to conventional radiography, we see that conventional radiography can distinguish tissues that have around a 10% difference in density. So there has to be a significant amount of density difference. But CT can really detect those tissues who have a density difference of 0.25% to 0.5%, depending on the scanner and the manufacturer. So we see that CT has a much better ability to visualize all the internal structures of the body. And so that's why CT has been so employed here lately. Low contrast resolution can be measured with phantoms that contain low contrast objects of different sizes. The low contrast performance or low contrast detectability of the scanner is typically defined as the smallest object that can be visualized at a given contrast level and dose. A 1% contrast means that the mean CT number of the object differs from it by only 10 Hounsfield units. So very small density difference in the grand scheme of things. So factors that affect low contrast detectability are, from the definition of LCD, it can easily be concluded that the visibility of the object depends not only on its size, but also on its contrast to the background. The low contrast Detectability definition also implies that an object's visibility is highly influenced by the presence of noise. So many factors affect the noise level in the reconstructed image, such as X-ray tube voltage in kV, tube current in MA, scan speed, helical pitch, and slice thickness. And if you'll notice, these are all operator controlled factors, so we can make modifications in the amount of kV that we use or the MA. We can also go in and modify the scan speed, how long it takes for a rotation, and not just a rotation of the tube, but also how long the scan will take in general by combing things in. Helical pitch, how much ground is covered per table movement, and also slice thickness, which is somewhat related to each of these. By decreasing or by increasing the tube current, noise reduction, better low contrast detectability can be achieved. So if you increase the tube current, you decrease noise. So increasing tube current decreases noise. And so what we do see though is the use of a higher tube voltage or tube current results in improved X-ray photon statistics, therefore lower noise in the image. However, the quality of the X-ray beam is somewhat compromised. And so what we see here is that basically you harden the beam. And consequently, low contrast detectability may not improve or degrade with increased kV. So if you increase your kV, you hopefully are going to decrease noise, but you also may decrease the low contrast detectability. The same applies to the selection of slice thickness. So basically you may increase slice thickness, which will hopefully eliminate noise, but it will decrease the amount of low contrast detectability that you have. So an image with a thicker slice contains more X-ray photons, which means less noise. The partial volume effect can reduce the visibility of small objects, though. And so because you may run into a type of error, you may actually not improve yourself at all. So here we have low contrast detectability. And we have not really high contrast objects. We have an area that's got a certain type of density, and then what we're looking for is the ability to image these circles. And so notice on image A we can find 4. Image B, on the other hand, we can see 3. So this would mean that A has a higher low contrast detectability versus image B. Here we see this applied once again. We have 1, 2, 3, 4, and potentially maybe 5 here. We have on image B 1, 2, 3, 4. So obviously image A has better low contrast detectability than image B. This brings us to temporal resolution. Temporal resolution is an indication of a CT system's ability to freeze motions of the scanned object. It's like the shutter speed of a camera. As we all know, the faster the shutter speed, usually the reduced risk of motion is in a person's photo. And we see that this is very important in cardiac imaging because the heart motion is continuous and often irregular. We find that cardiac imaging is one of the most challenging clinical applications of CT, and as we can all attest to, it hasn't been fully completed with high degrees of accuracy yet. So factors that affect temporal resolution are increasing the scan speed. That is one way that you can decrease the amount of time that it takes to acquire an image and instantly bolster your temporal resolution. You see that electron beam scanners have the ability to scan speeds as high as 33 milliseconds, but even at 33 milliseconds, it's insufficient to completely freeze cardiac motion. You still have to go faster than that. All third-generation CT scanners rely on reconstruction algorithms that use less than a full rotation of projection data for reconstruction, with the most commonly used algorithm being the so-called half-scan algorithm, which the projection dataset is used in the range of 180 degrees plus fan angle. So basically, even the fastest thing that we have does not have the ability to actually image the heart with a high degree of accuracy. So because of that, we're still working on temporal resolution because we do not have the ability to freeze motion. That's where cardiac gating is actually coming into play and things like that. And so they're making progress all the time, but we're still waiting to see all of the significant progress. So the techniques to reduce motion, as we know, this motion is the arch enemy of CT. So the way to increase temporal resolution instantly is to decrease motion. So a technique used by all CT vendors incorporates a physiological gating device for cardiac imaging. In a typical cardiac motion cycle, there are quiescent time periods in which the heart is in a relatively motionless state. That corresponds to the T wave. These correspond to the diastole and systole phases of the heart. So the techniques to reduce motion. A technique used by all CT vendors incorporates a physiological gating device for cardiac imaging. In a typical cardiac motion cycle, there are quiescent time periods in which the heart is in a relatively motionless state. This corresponds to the T wave of the EKG cycle. These correspond to the diastole and systole phases of the heart. If the data acquisition takes place during these time periods, fewer motion artifacts can be expected. So basically what happens is we use cardiac gating to analyze what phase the heart is in, and then as soon as the heart hits a relaxation phase, a scan is acquired. And so this keeps on going and going and going until the heart is completely imaged. This can be performed either retrospectively or prospectively. The advantage of a prospective gating is the reduction in X-ray dose to the patient. The X-ray tube can be shut off during the non-data acquisition periods to minimize the X-ray exposure. Not all of the commercial available CT scanners today can cover the entire heart, which is 12 to 16 centimeters in a single rotation. Consequently, the heart volume has to be scanned over multiple heart cycles, with each cycle covering a subsection of the heart. So basically, we see that 64 slide scanners have the ability to somewhat cover the entire heart, but 256, 128 and 256 all have the ability to cover the heart in almost one rotation, 256 being the one that has the greatest prospects of doing that. The problem with all of this is that it does not guarantee that the heart is in exactly the same state from one subsection to the next. So while we are trying to scan in the same phase constantly, it does not mean that the heart is always going to be in this same location. And because of that, you may actually get very, very misguided images. So the probability of a stable heart rate decreases quickly as the total data acquisition time increases. And so as the patient tends to be inside the CT suite for a longer period of time, they get a little more disruptive and concerned when it comes to looking at their heart rate. So here we see image A without cardiac gating and image B with cardiac gating. As you can see, there's all kinds of motion throughout the heart. We can see that we have left atrium, we have what looks to be probably the ascending aorta, maybe the superior vena cava, descending aorta, but that's really all we can make out. So if we go over onto this image, we see that we can really demonstrate the left atrium, ascending aorta, pulmonary trunk, superior vena cava, descending aorta, all of these with great visualization. And notice we can see some of the coronary circulation as well coming here. And so cardiac gating is a technique that works very well, especially if you have the capability of imaging the heart in one rotation with a 256 slice scanner. So that brings us to CT number accuracy and uniformity. CT number uniformity dictates that for a uniform phantom, the CT number measurement should not change with the location of the selected regions of interest or with the phantom position relative to the isocenter of the scanner. So basically what this does, or what this is trying to tell you, is that theoretically the average CT numbers in two regions of interest locations should be identical. So basically what we're looking at is, if you take a phantom and you're scanning through it, and you were to take a region of interest from this area and this area, you should see that CT numbers should be identical. If you were to move this region of interest here, you should see pretty much the same numbers that are coming up, and you shouldn't see a great difference when you're scanning through the same thickness. Because of the effect of beam hardening, scatter, stability of the system, and many more other factors, the CT uniformity can only be maintained with a reasonable range, typically 2 Hounsfield units. So as you can see, we have the ability to distinguish CT images and CT density differences of tissues between 10 Hounsfield units. And so there should not be a density difference when scanning through the same area of greater than 2 Hounsfield units. So here we see this actually lined out. We have a region of interest here and a region of interest here. And so if we got a Hounsfield unit for this one of, let's say, -300, then we should get theoretically a Hounsfield reading from this one of -300 because they're the same tissue density difference. However, if you were to take a region of interest out here, then we would expect to see vastly different areas because we're scanning through bone, air, and even brain. So that brings us to the sources of noise. There are 3 major sources that contribute to the noise in the image. The first source is the quantum noise determined by the X-ray flux or the number of dedicated X-ray photons. It's influenced by the scanning techniques such as the X-ray tube voltage, tube current, slice thickness, scan speed, and helical pitch. The scanner efficiency, such as detector quantum efficiency, detector geometrical efficiency, amber penumbrum ratio, and the patient, such as patient size, amount of bones, and soft tissue in the scanning plane. More advanced scanners offer features that allow the operator to select a noise level, and the CT system will determine the X-ray tube current required to achieve the specified noise level. The second source that influences the noise performance is the inherent physical limitations of the system. Included in this are the electronic noise in the detector photodiode, electronic noise in the data acquisition system, scattered radiation, and many other factors. The third noise influencing factor in the reconstruction parameters is the reconstruction parameters. In general, a high-resolution reconstruction kernel produces an increased noise level. This is mainly because these kernels preserve or enhance high-frequency contents in the projection. So what it does, these high-resolution reconstructions have a tendency to amplify all of the data that is already there. And so while it will help bring out certain points of the data, it will also bring out certain negative points of the data as well. And so you'll see an increase in noise. So that brings us to image artifacts. Artifacts can degrade image quality, affect the perceptibility of detail, or even lead to misdiagnosis. Therefore, it is mandatory that the technologists understand the nature of artifacts in CT. In general, an artifact is a distortion or an error in the image that is unrelated to the subject being studied. So basically, it's not something that is inherently in the patient, but it's something that is caused outside of the patient or what you're actually looking at. A CT image artifact is defined as any discrepancy between the reconstructed CT numbers in the image and the true attenuation coefficients of the object. Basically what it is this last bullet point. It implies anything that causes an incorrect measurement of transmission readings by the detector, and that is an image artifact. So basically, it's an incorrect detector reading caused by something other than inherent in the patient. In CT, artifacts arise from a number of sources, including the patient, inappropriate selection of protocols, reconstruction process, problems relating to the equipment such as malfunction or imperfections, and fundamental limitations of physics. Typical commercial CT systems, in a typical commercial CT system, an image is reconstructed from 106 independent projection samples. As a result, the probability of an artifact for CT is significantly higher compared with conventional radiographs. And that's why artifacts have a tendency to disrupt CT images much more than they do conventional radiography images, because there are so many points of data being sampled. 4 major categories can be identified, including streaks, shadings, rings, and bands, and miscellaneous factors such as the basket weave and Moiré patterns. Streak artifacts may appear as intense straight lines across an image, and it's caused by improper sampling of the data, aliasing, partial volume averaging, motion, metal, beam hardening, noise, spiral helical scanning, and mechanical failure or imperfect islands. It's caused by errors of isolated projection readings, and it's enhanced by the convolution process. So streak artifacts are only going to get worse when they pass through the filter. Ring or band artifacts are produced when the projection readings of a single channel or a group of channels consistently deviate from the truth. This is predominantly a third generation scanner problem, not usually found in fourth generation, but only in third. Shading artifacts often appear near objects of high densities and can be caused by beam hardening, partial volume averaging, spiral helical scanning, scatter radiation, off-focal radiation, and incomplete projections. It's formed by the gradual deviation of a group of projection readings over a limited range of views. Additionally, we see that patient motion can cause artifacts. Patient motion can be voluntary or involuntary. Voluntary motion, as we know, is directly controlled by the patient, such as swallowing or respiration. Involuntary motion is not under the direct control of the patient, such as head motion with injury, peristalsis, and cardiac motion. Both voluntary and involuntary motions appear as streaks that are usually tangential to the high contrast edges of the moving part. Additionally, motion artifacts can arise from movement of oral contrast agents in the gastrointestinal tract. There are several methods to reduce CT artifacts from motion. For patient movements such as breathing and swallowing, it's important to immobilize the patients and use positioning aids to make them comfortable and ensure the patient understands the importance of remaining still and following the instructions during scanning. Also, scan times can be reduced so that you eliminate or hopefully reduce the amount of time that the patient can be moving. So here we see basically patient motion, image B and image A. Image A has tons of patient motion, and as you can see, you have these lines that are running through the patient's head. It's most prominent here in the eye, and image B does not contain this. It looks more of a uniform image, and that is simply because the patient is not moving. Even very slight motion can cause this. I've had actually patients, some breathe kind of heavily through the mouth, and as they are breathing in and out, their head is slightly rocking back and forth, and that results in this pattern. Additionally, you may have this image. This is what it looks like when a patient is breathing. In image A, as you can see, the abdomen where the patient is breathing has streaks throughout it. This would be a streak artifact, but also it would be a breathing or patient motion artifact. Notice when the patient actually holds their inspiration, we don't get any of this. One of the most common artifacts that will probably ever see is metal artifacts. The presence of metal objects in the patient can cause artifacts. Metallic materials such as prosthetic devices, dental fillings, surgical clips, and electrodes give rise to streak artifacts on the image. So basically, anything that the patient may have embedded in them, such as Harrington rods in the spine, any spinal device, even EKG leads, can cause metallic artifacts, and they're going to look like streak artifacts. The error is the combined effects of a signal under the range, beam hardening, initial volume, and limited dynamic range of the acquisition and reconstruction systems. So the loss of information leads to the appearance of a typical star-shaped streak. Software such as the Metal Artifact Reduction, the MAR program, can be used to complete the incomplete profile through interpolation. The easiest solution is to have the patient remove all metallic items before scanning, which is a nice thought, but there are a lot of things that the patient sometimes cannot remove, and so it becomes very necessary to employ all techniques that we can to utilize and give the patient the best diagnostic results. Radiologists, however, are often interested in the region immediately adjacent to the metal implant to assess the patient condition. So I see that I've actually seen it several times where CT thoracic spines or CT chest have been ordered with the patient having Harrington rods throughout their spine, and so many times the images just wouldn't be of great quality simply because of what the patient had embedded. However, it was a necessity that we performed the scan, so some degree of information was better than no information. Many correction methods, such as the one outlined previously, do not preserve the integrity of such regions. So here we have an uncorrected scan. As we can see, the patient has cups installed in their acetabulum, and they have bilateral hip replacements as well. And because there's such high density metal, we see that we have all these streaks kind of coming out, and they're even coming over from each other and kind of doing this number here. And so that is typical of metallic artifacts and streak artifacts in general. That brings us to beam hardening. Beam hardening refers to an increase in the mean energy of the X-ray beam as it passes through the patient. As the object size increases, the mean energy shifts to the right because lower energy photons are absorbed preferentially as the beam passes through the object. We see that there is less beam hardening at the periphery of the object where the radiation path is short compared with the center of the object where the radiation path is longer. So, what happens as a result of beam hardening is this. Higher energy photons make it through and cause artifacts like this in the center. And that's because these photons come out of the patient at such a higher energy, whereas usually on the periphery they are scattered or deflected. And so to correct this, we have beam hardening algorithms which help to remove that, and we have an image like this. The reason beam hardening can be detrimental to the patient is simply what we have here versus image B. It would be very easy to mistake this for some type of lesion or mass, whereas if it's corrected, like on image B, we can clearly see that there is no mass there. And so you don't want to mistake the patient for having an ischemic stroke, things like this, simply because of artifacts or evidence. And so that's what we seek to remove, and why we seek to remove beam hardening. You'll hear this tossed around a lot as well, partial volume averaging or partial volume artifacts. We see that CT numbers are based on linear attenuation for a voxel of tissue. If the voxel contains only one tissue type, the calculation will not be problematic. So basically, if for one CT number we get 85, that would correspond, we would think, to one specific tissue. If the voxel contains two types of tissues or three similar types of tissues, the CT numbers are close together, like blood, gray matter, and white matter, and the CT number for that voxel is based on the average of those three tissues. And so what you may see displayed is going to be 43. That's going to be your average. And so it could affect how things actually appear. When the voxel contains multiple materials that are significantly different, such as soft tissue and bone, partial volume averaging can lead to partial volume artifacts. These inaccuracies result in partial volume artifacts in the image which appear as bands and streaks. Partial volume artifacts can be reduced with thinner slice acquisitions and computer algorithms. So basically, if you have plus 1000 and then you have 0, the average is going to be plus 500. And so that would significantly kind of be inaccurate for this area. Here is a partial volume averaging. Notice the posterior portion of the patient's skull. Here it would seem that the patient has an ischemic stroke based on this large area. However, with that recorrected, we see that this area is totally normal. And that's because of differences in CT numbers between the skull and the brain, which causes a significant portion to be inaccurate. So noise-induced artifacts. Noise is influenced partially by the number of photons that strike the detector. Photon starvation can occur as a result of poor local patient positioning of the skin, SOV, SVOV, and poor selection of exposure techniques such as peak, KV, MA, scan speed, limitations of the CT scanner, such as maximum tube power. More photons mean less noise and a stronger detector signal, whereas fewer photons result in more noise and a weaker detector signal. And so basically, we can understand this from just conventional radiography. If improper technique is utilized where enough KB is used or enough MA, we will see that the image has quantum noise on it, a quantum model, where you have this grainy, blotchy appearance, and that can simply be called starving the system. And that's what can be employed in terms of CT as well, where improper techniques are utilized and not enough photons are actually reaching the detectors. Cone beam artifacts. They're caused by incomplete or insufficient projection samples as a result of the cone beam geometry of a multi-slice CT. The comparison of a relatively centered slice and an edge slice shows both distortions of the dense oval objects as well as shading artifacts nearby. Reduction and elimination of cone beam artifacts have been the focus of intense investigations in recent years, and this research will likely continue for years to come. So here we have cone beam artifacts on image B and the resolution of cone beam artifacts on image A. As we can see, when we get to the edges of the scan field, we have these artifacts. When we correct them, we see the nice smooth objects that should be visualized without any artifactual evidence. But notice that they almost appear as streaks, but they kind of have the band type of appearance as well. Also notice that as a result, we have this included as well.